This meeting is called to order. If everyone will rise with me for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Okay. Colleen, would you take roll call, please?
Director Danielson?
I'm present.
Director Wallace?
Present.
Director Stewart?
Present.
Director Nicholson?
Present.
Director Ethan is off wait.
Okay. Nancy, we have some educational sessions
Yes, I'd
next
be
on the
very
agenda.
pleased to introduce our first education session. Speaking tonight is Michael Platzbecker, RN. He's been with Washington Hospital for 21 years. He's a registered nurse with a Bachelor of Science degree in nursing and is a certified emergency nurse. He is the current manager of our emergency department.
Good evening. I was asked to present a brief overview of the sexual assault response program at Washington Hospital. The state of California mandates that counties have a sexual assault response program, and each county has to provide services. It's a holistic approach. They take care of the psychosocial needs of the patient, involving counseling the victim, and as well as the forensic evidentiary collection and any outstanding medical issues that they may have concurrently. On average, there are 500 sexual assaults per year in Alameda County. Last year, 10% of the annual was in Washington Township District. The program at Washington Hospital was, the inception of the program was 2002 in collaboration with the Fremont Police Department and the Alameda County District Attorney's Office. Here's a collection of the various agencies that we deal with. We also deal with the Pleasanton Police Department and Livermore Police Department. We've expanded our catchment area. And right now, we are one of only 2 programs in Alameda, the services in Alameda County. The other one is in North Alameda County at Highland Hospital. So it's following Ms. Farber's dictum with the patient first ethic. We try everything we can to keep the local victims in county, so, I mean in our district, so they don't have to travel all the way to Highland to receive services. And since Valley Care and Pleasanton closed the program in 2009, we've increased our catchment area to those. As a show of support for the counseling services, there was a donation of $10,000 to BAYWAR, which is a Bay Area Women Against Rape advocacy group. And we also deal now with the Tri-City Haven in Pleasanton as an advocacy group. Like I mentioned, it's a patient-centered, victim-centered care. And when they come, we serve all patients, all victims 14 years and older. If they're under 14, by county dictate, they go to Children's Hospital. When they come into the emergency room, they're quickly identified. If they present on their own, they're identified as a potential victim. They're rapidly triaged and escorted to a private area in the ED for further assessment. If they come with the police typically give us a little bit of a heads up, but the same process. We bypass triage pretty much and put them in the quiet room in the ED to get a little bit more history. When we identify that a SART exam will occur, we take them up to the short stay unit on 3 East, the old pediatric unit, and we have a special room up there dedicated to provide the care. It's got a counseling room as well as a treatment room, private showers, private baths, and we can escort them up kind of the back of the hospital so to maintain some modicum of privacy. We have a 24-hour team approach to provide coverage. We intend to provide the coverage if the nurses are working. We have on-call nurses when the nurses aren't working. We have a commitment with the state-of-the-art equipment. In 2009, we purchased a $28,000 colposcope, which allows for hands-free visualization as well as documentation with JPEG images of the exam. Like I said, the victim advocacy is a strong role for the nurses, and we advocate that an advocate attends. However, the victims can decline it, but we try to provide the service, and they follow the victim through the whole process when they leave the hospital and go through the litigation. The objectives of the program was to provide for the advocacy of care, quality forensic examinations, as well as the psychosocial needs. And the skill of the nurses is paramount to ensuring that we have accurate data collection, and we work closely with the DA and the Alameda County Crime Lab to make sure that they get feedback, the nurses get feedback to assure that we're doing the collection adequately. We provide services for the district residents, obviously Fremont, Newark, Union City. We now have, our catchment area includes Pleasanton and Livermore, the BART, if it occurs in Fremont BART Station, and the Southern Alameda County Sheriff for parts of Hayward, I think. And the SART program is maintained by specially trained RNs, predominantly from the emergency department as well as the birthing center. They initially undergo an intensive 5-day training at the UC Davis Forensic Medical Training Center, followed by a preceptorship and clinical orientation here at the hospital. The orientation and training includes an annual live model evaluation, which they get instantaneous feedback for their technique. We also work with the Alameda County SART coordinator at Highland to make sure that the data collection and documentation is up to standard. Currently, we have 7 SART nurses, 6 in the ED, and 1 in L&D. 2 of the emergency department nurses are with us now. Staff Nurse 3 Betty Goodwin, as well as Mary Lou Moy from the department. For the calendar year, for service utilization, calendar year 2013-2014, we had 20 exams in 2013. We had 33 exams last year. So far this year, we've had 4 exams, which have been problematic, but due to the dedication of the nurses, we were able to actually do those exams in spite of our exceedingly busy 2 months we've had. So that was quite an accomplishment on their behalf. In 2014, in May, we joined forces with the Department of Justice and the Alameda County Crime Lab, as well as the DAs, to take part in the RADS program. And what the RADS program is in addition to the typical evidence that they collect additional swabs which are submitted to a database. And that database is cross-referenced for any known felons. And this is data from October, but we had 1 case hit, which means that they had an adequate DNA profile, what they were able to run in the system, and they were able to identify a perpetrator that was already in custody with an additional crime. So the accomplishment, it's mainly due to the guidance of Stephanie Williams, the Chief Nursing Officer, as well as the commitment of the nurses, but we attempt to have regularly scheduled meetings. Like I said, we have ongoing analysis with the SART coordinator to make sure that the data collection is adequate, and we were able to train 3 additional nurses in September of 2014 to increase our coverage. And we have not had a non-SART capability in the last year and a half. We've been able to accomplish and take all of the patients, victims that were presented, including the ones from the increased catchment area. We had a multi-agency meeting in October of last year, which was attended by the Alameda County Crime Lab, the Assistant District Attorney for Sexual Assaults, the SART coordinator, and the various SART nurses. The next step, we want to complete the orientation, which actually has occurred now. All 3 of them have precepted and performed their own case, so now they're independent examiners. We want to evaluate any current technology that we can incorporate for the exams. We want to facilitate some skills development, send them to some classes. One of our nurses took part in a judicial class, testimony class, which was particularly helpful since she did get called on a case. And in July of this year, we are going to participate in a forensic photography class. Any questions?
Michael, thank you for your presentation. You said that there was 500 cases in Alameda County, but on the one slide it looked like the numbers were really low down here in South County.
Yeah, we
Is that
had-
correct?
Yeah, we had 10% of those 500.
10%,
Yeah,
okay.
so, but we're increasing our service utilization, but we didn't turn anyone away. So those were just the cases that were presented to us, either walk-in or were presented with the various law enforcement agencies.
Okay, thank you. And the nurses that are doing the job. Thank you. Nancy, would you introduce our next speaker?
Yeah, very pleased to introduce our next speaker. I suspect the board now knows him well. Speaking tonight is Paul Kozachenko. He's district counsel for Washington Hospital Healthcare System, a position he's held since 2007. He's a partner in the Fremont-based law firm of Gonzalez and Kozachenko, which he helped to found in 1984. He's been practicing law for over 30 years. He is rated AV, preeminent, by Martindale-Hubbell Lawyers Ratings, and it's the highest rating possible. His name appears in the 2014 edition of Legal Leaders, which lists San Francisco area's top-rated lawyers. Prior to founding his firm, he worked in the tax department at Coopers & Lybrand, which is now PricewaterhouseCoopers, where he handled partnership, corporate, and individual tax matters. He formerly served as a director and a president of the Fremont Chamber of Commerce. He's a member of the American Health Lawyers Association and the California Society for Healthcare Attorneys. He's also a member of the business law section of the California State Bar Association. He was born and raised in San Francisco, California. He obtained his Bachelor of Arts degree from Stanford University in 1979 and his JD from Santa Clara University in 1982. He was admitted to the California Bar that same year, 1982.
Good evening, members of the board, Nancy, and all the members of the public. I'm here tonight to talk about the Ralph M. Brown Act and healthcare districts on a sort of an overview level. But before I get into the actual discussion of the Ralph M. Brown Act, I want to talk about some context, because I think it's very important that the public understand the context with which the district operates. So this picture here is a shot from your website, and I thought it was apropos because it shows a physician and patient relationship. And of course, the district is all about facilitating and supporting this fundamental task of the district, which is the physician-patient relationship. And there's two key elements that impact that relationship that are of major concern to the board. First, obviously, is the quality of that health care. And secondly, something inherently we all know, which is privacy. We all go to our physicians and we expect to be able to tell them about issues relating to our health in a private manner. Indeed, on our district's website, there's a short video with a focus on quality, which begins with an introduction by our own Dr. Nicholson, who says, "All of us at Washington Hospital are deeply committed to a culture of quality and safety. Healthcare is an intensely personal service. Our reason for being begins and ends with our patients and our community." And that just underscores the need for a concern of privacy. But it's not just because we inherently believe in privacy or because it's existed in the physician-patient relationship for centuries. The federal government and the state government both insist on very strict privacy rules. Federal government has a statute, the Health Insurance Portability and Accountability Act of 1996. We know it as HIPAA. And the state law, which is a parallel law, is the Confidentiality of Medical Information Act, sometimes referred to as COMIA. That's one context that I think is very important to keep in mind. The second context, well, this is a picture of the hospital, okay? And this is sort of a reminder that the hospital is a multifaceted healthcare provider. It's complex and it's heavily regulated. Generates a lot of patient revenues. Net patient revenues fiscal year to date are $226 million. These revenues do not come from from the taxpayers, but come from the provision of healthcare services. Unlike cities and counties, the district has to compete with private and other public providers for patients. The district serves thousands of patients a year. The last point of context that I think is important before we get into the Brown Act is the role of the board. And just so that the public can understand, it's important, I think, to note this. As a board of directors, you're responsible for oversight and for making informed decisions. You were elected, you took an oath of office, and in order to exercise oversight and informed decisions, you need information. And given the business of the hospital, much of that information is information that is provided in a confidential manner. So with that backdrop, I will now turn my attention to the Brown Act. Okay. Brown Act equals open meeting law. That's what it's otherwise referred to. In enacting the Brown Act, and it can be found starting with Government Code Section 54950, there's a declaration of public policy. I'm not going to read the whole thing, but the legislature adopted the following. In enacting this chapter, the legislature finds and declares that public commissions, boards, and councils, and other public agencies in the state exist to aid in the conduct of other people's businesses. It is the intent of the law that their actions be taken openly and that their deliberations be conducted openly. So, what are the basics? We all know them, but it's important to go over them. Meetings. All meetings are open to the public unless an exception applies. Okay? Meeting means any congregation of a majority of the members of the legislative body to hear, deliberate, discuss, or to take action on any item that is within the subject matter jurisdiction of the legislative body. The other requirement of the Brown Act is you have to have agendas. All meetings must be noticed and an agenda must be posted, usually 72 hours in advance. An agenda must contain a brief general description of each item to be transacted or discussed at the meeting. And items not on the agenda are not to be discussed, and you can't take action on them. That's another basic requirement of the Brown Act. Another basic requirement is the public must have an opportunity to address the board on each agenda item and also on items that are not on the agenda. And for as long as I've been here, and I think it's been since the beginning of the district, there's always been a placeholder for members of the public to come and address the board about items that are not on the agenda. So those are the basic requirements of the Brown Act. But the Brown Act also contains a number of exceptions. Okay? We refer to these generally as closed sessions, as most public agencies do. And all public agencies have a number of exceptions that are available to them. And they can really be categorized or described as common sense exceptions. These are exceptions that the legislature adopted because otherwise the public agency would be placed at a disadvantage. One of them, actual or anticipated litigation in a consultation with legal counsel. Obviously, that kind of discussion can't occur in a public meeting. It would place the agency at a huge disadvantage. Other exceptions that are applicable across the board. Personnel matters. We can all understand why those need to be held in closed session. Meeting with real property negotiator. If an agency was acquiring property, you wouldn't want to discuss negotiating strategy before making an offer. Meeting with labor negotiators. Again, all of these are designed to avoid disadvantaging the public agency. But there are also exceptions that are available only to healthcare districts. I'm going to talk about those. And I want to point out that with regard to closed sessions, the Brown Act also requires that those be held strictly confidential and that information that is discussed at those closed sessions not be disclosed to anybody not entitled to the disclosure unless the entire legislative body agrees. Okay, let's talk about the two main exceptions that apply to hospitals. The first one is under trade secrets, and it's in Health and Safety Code Section 32106. The Board of Directors may order that a meeting held solely for the purpose of discussing or deliberation or both of reports involving district trade secrets be held in closed session. Healthcare facility trade secrets are used in this section, and it means trade secret as defined in the Civil Code and which meets the following criteria: is necessary to initiate a new district service or program or add a district healthcare facility. And 2, would, if prematurely disclosed, create a substantial probability of depriving the district of substantial economic benefit. And we can understand, since the district competes with other healthcare providers for patients and depends on the revenue of patients for the operations, that disclosing potential business opportunities before they occurred would put the district at a disadvantage. Indeed, the legislature considered this, and in the legislative intent history of the statute, the legislature wrote the following: because district hospitals are subject to public meeting and disclosure laws, they are, with growing frequency, forced to disclose financial and planning information in the nature of trade secrets, which information is of value to competing hospitals. Therefore, it is necessary, in the interest of providing healthy competition for healthcare services, to provide a limited exemption to district hospitals for purposes of the laws pertaining to open meeting and public records. I think that statement pretty much speaks for itself. The other major closed session exception for hospital districts is the exception regarding peer review and reports from medical audit and quality assurance committees. This section simply says that the Board of Directors may order that a hearing pursuant to this article and hearings on reports of the hospital medical and audit quality assurance committees be held in private or executive session, and deliberations can be held in executive session, which is another word for closed sessions. And we can understand why that's important. Again, remembering what the district does. It facilitates that patient-physician relationship. In instances of quality assurance and peer review, those discussions need to occur in private because it involves physician performance, it involves patient privacy. Again, a major aspect of what the district does. I want to now turn my attention to transparency. And I think the district and its board has always endeavored to be as transparent as possible. But nevertheless, recently we've adopted some transparency enhancements. And I want to note those for the records. Board packets now are posted online ahead of time. In the past, when someone asked for board information, we provided it to them, but now it's posted automatically, available to anybody with a web browser. The form of agenda has changed to provide more detail in an effort to provide more clarity. Our CEO's contract is posted online, again in the spirit of transparency. And of course, this board's holding this education session in an effort to educate the public about why it needs to meet in closed session and why it is different from cities and counties. I started this presentation with a picture of this relationship, and it really all boils down to the physician-patient relationship. And the district is about facilitating that relationship. I've been working with the staff, physicians, and the board, and Nancy for 7 years now, and I know how seriously you take the patient-first ethic. If I were a patient at Washington Hospital, I would always want you to err on the side of patient privacy, and I would always want you to err on the side of patient quality. In order to do that, the board has to have access to certain confidential information, without which it would not be able to accomplish its duty to make informed decisions and to exercise appropriate oversight. I'm willing to take any questions if anybody has any.
No questions, Paul, thank you.
Okay.
We will now take consideration of the minutes of January 14th, 19th, 26th, and 28th of 2015. May I have a motion, please?
So moved. Second.
Motion has been made and accepted. Would you take roll call for the vote, please?
Director Danielson?
Aye.
Director Wallace?
Aye.
Director Stewart?
Aye.
Director Nicholson?
Aye.
And Dr. Eapen is away.
Next item on our agenda is oral communications. Colleen, just double checking, you did not receive any
No.
notice of it. Would anybody in the audience want to come up for oral communications? Now's the time. Okay. Seeing no one, we will move on to written communications from Dr. Lunny. Thank you.
So I have the credentialing action items from the medical staff for January. We have 2 new applicants for appointment. The first is Anna Chun, a PA, and the next is Steve Pham, MD, Emergency Medicine. Anna Chun currently has temporary privileges while pending board approval. For reappointments, 2-year reappointments, we have Dr. Elizabeth Arias, Internal Medicine, Dr. Stephen Belton, OBGYN Hospitalist, Dr. Bhupinder Bandari, Gastroenterology and Medicine, Dr. Gordon Epstein, Otolaryngology and Surgery, Dr. Puya Jazayeri, Anesthesiology, Dr. Glara Kang, Pediatrics, Ambulatory Status, Dr. Chai Kong Lau, Internal Medicine, Dr. Philip Lee, Internal Medicine, Dr. Dewan Liu, Intensivist, Critical Care Medicine, Dr. Bruce Nixon, Radiologist, and Dr. Lucia Jimena, Nephrology and Medicine. In the spirit of transparency, I'd like to acknowledge that Dr. Jimena is the spouse of one of our board members, Dr. Nicholson. For transfers in staff category, Dr. Dennis Martinez will be going from provisional to active status. Completion of proctorship and advancement in staff category. We have Dr. Vacha Bezdikian, Anesthesiology, Dr. Shashank Jolly, Cardiothoracic Surgery, Dr. Vaibhav Medikar, Internal Medicine Hospitalist, and Dr. Rajesh Singhal, Urology. Completion of proctorship prior to eligibility for advancement in staff category. We have Dr. Jack Rose, Neurology. New privilege request. Dr. Naveen Paul Bhatti is requesting privileges in hyperbaric medicine and currently has temporary privileges while he's being proctored. Withdrawal of privileges. Susan Glabiger, PA, has withdrawn a number of her privileges, including nasogastric tube and lavage, thoracentesis, pulmonary arterial line removal, arterial line insertion, chest tube insertion, chest tube removal, central line insertion and removal, arterial punctures, assisted cath lab procedures, intra-aortic balloon pump removal, and temporary pacemaker wire removal. Resignations. Dr. Shannon Crawford, Radiology, Dr. Ranu Grual Bal, Radiation Oncology, Dr. Sarbjit Hundal, Ophthalmology, Kimberly Kurtz, PA, David Lieberman, MD, ENT, and Dr. David Voon, Pediatrics.
Further instructions would be that we need to have 2 separate motions from the board, please, with Dr. Nicholson abstaining from Dr. Umana's re-credentialing. So if I could have a motion, please,
So moved.
for everybody except?
Yeah.
Okay, thank you. Do we have a second?
Second.
All in favor?
Aye. Aye.
No, 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 no. No, we have
That's
to,
right.
roll call. You jumped ahead of me, guys. Okay. Colleen, would you please take roll call?
Director Danielson?
Aye.
Director Wallace?
Aye.
Director Stewart? Aye. Director Nicholson.
Aye.
And Dr. Ethan is away.
And we need a separate motion for Dr. Umana, which would exclude, or did you already?
No.
You excluded? Okay.
That was the motion excluding Dr. Umana. Dr. Umana is my wife.
Yes, I know.
25 years, my Valentine.
Congratulations.
And I must, specifically with respect to the Brown Act, abstain.
I understand that, but I want to make sure she gets back on staff and stays on staff.
That would be good. Her patients would appreciate that.
I did, trying to do my best here. Okay. So, Colleen, would you clarify for me, do we have a motion approving Dr. Umana?
Yes.
Okay, so we're done. We're cool. Thank you.
No,
No,
you
no,
don't
we
vote.
need to do a
Yep.
motion
Okay.
specifically
Do a
for her,
motion.
because the last motion
Thank you.
excluded her.
So I move Dr. Umana.
We'll get it straight, folks. We'll get it straight. Okay, so I will entertain a motion to
So
approve. Okay,
And I second that.
All right,
For
thank you.
Dr. Umana alone.
thank you. All right. Roll call, please.
Director Danielson.
Aye.
Director Wallace.
Aye.
Director Stewart.
Aye.
Director Nicholson.
I abstain.
Thank
Dr.
you.
Ethan away.
Okay, everybody's been approved. Good. See, the Brown Act is not as easy as Paul made it sound. We're trying our best to follow the law and follow the rules and make sure that nothing is violated. So, pardon my stumbling. Thank you. All right. Now, we are at that point on the agenda for the Service League report, and we have the new president with us. Debbie, please.
Thank you. Thank you. I'm excited to be here. First of all, my name is Debbie Jackson. I'm your new president-elect. I take terms beginning of March. I'm filling in for Gail today, as Gail is in Japan on vacation. Lucky lady. So I have her report to give to you guys. And first of all, we had our annual meeting, as many of you know, on February the 2nd, and it was our 60th annual meeting for the Service League. And they presented the new board for the 2015-2016, which is Debbie Jackson as president, first vice president Jose Aguirre, second vice president Pooja Maan, secretary Shelley Chu and Barbara Wong co-chairing, treasurer Donna Lim, and parliamentarian Jeannie Yee. Our annual donation was given to the hospital and presented to Nancy at the annual meeting. And we were happy to donate $60,000, which is, I think, awesome. I'm so excited to we were able to do that. And the money that is going to be used for is the Arctic Sun temperature management system. And the rest of the money will go to the intra-aortic balloon pumps. This brings our total donation to the hospital of $2,429,406.68. So, yay. And I'm very proud to be able to tell you that. So, now, the Service League was incorporated on March 28th, 1955. This year will mark the 60th anniversary of the Service League, and we will be having a wonderful celebration on October the 13th to celebrate that. And we want to thank the hospital for making that so special for us. We're totally looking forward to it, and I'm really hoping all our volunteers will be there to enjoy this time as well. And thank you very much to those who did come to the board, who did come to the annual meeting and spoke, and it means a lot to us Service League volunteers. Thank you.
Thank you, Debbie, and welcome. You've done an excellent job at filling in.
Thank you.
And we will formally welcome you when you are actually the president. But thank you, and thank
my
you for
pleasure.
coming. And the luncheon was lovely as always. I particularly like how the officers are installed and the creativity that is shown on all the little things for each particular task that's to be done. So,
Well, they asked the incoming president if they have something that's special to them, and for me, mine is gardening. I love to garden, and I thought that was so appropriate to share with that theme, and thank you to Cherie, who did a marvelous job at doing that presentation. And she's here this evening, and it was just, it's nice, and everybody has their own thing that's very special to them, and mine is I love to get out in the yard and garden and make things beautiful and watch them grow, and that's what volunteers do, too.
And I like the idea of the trowel. I can see him raking in the money.
Yes. Oh, for Jose.
Yes,
For
yes.
Donna. For Donna,
Yeah.
our treasurer. Yes.
Yeah, perfect.
Yes.
Perfect item for him.
Thank you very much.
Thank you. We look forward to working with you for the
Thank
next year. Thank you.
Madam President, I just wanted
Yes.
to make a brief comment.
Please.
about, what a beautiful thing it was for you to give the two items, the intra-aortic balloon pump and the Arctic Sun device.
Uh-huh.
You don't really realize how important those devices are in the work that we do. And I can see our ICU nurses out there saying, yes, yes,
Yes.
we got it. But truly, those two things are gifts of life
Yes.
because they are used in treating patients who are critically ill or who have had cardiac arrest or both. And I know there will be many patients who will benefit tremendously and families who will be so appreciative that their loved one was
Well-
able to survive through your gifts.
Thank you. That gives me the chills, and we're happy. We're very blessed to be able to do that for you.
Thank you so much.
Thank you.
Would other board members like to make a comment? No? Okay. Thank you. Thank you.
Thank you.
Hard work to earn that money.
Yes. A lot of love of what we do.
It's appreciated.
Thank you.
Thank you. Okay. Next item on our agenda is the medical staff report by Dr. Lunny.
Thank you. I'd like to echo Dr. Nicholson's sentiment too regarding the donation of that equipment for the critical care unit, so we can continue providing quality care and have state-of-the-art equipment.
Thank you.
I'd also like to acknowledge that several members of our medical staff were involved in a medical mission to the Philippines last month, I believe, to an area that was hit by the hurricane, I believe, last year. So moving on to our current medical staff composition, we are up to 550 total medical staff members, 336 active members, 95 provisional, 27 courtesy, 64 ambulatory, 20 allied health professional members, and 3 administrative medical staff members. We've kind of made some headway in terms of our backlog of applications, so we're currently down to 10 applications total, 5 applications in process and 5 pre-applications, 7 of which are from physicians and 3 allied healthcare professionals. And that's all I have to report.
All right, thank you. Thank you. Next item is our hospital calendar. Nancy, would you update us on that,
Yeah,
please?
With our video, please, Chip.
Past health promotions and outreach events. During the month of January, Lucy Hernandez, Community Outreach Coordinator, presented 6 hand hygiene classes for students at Chadbourne Elementary School, located in Fremont, and Alvarado Elementary School, located in Union City. Information was provided on proper hand washing and hygiene to prevent infection and the spread of germs. 176 students participated. On January 11th and 17th, Michelle Heading, Spiritual Care Coordinator, presented on advanced healthcare directives at Mission Peak Universalist Unitarian Church in Fremont and Palmacia Baptist Church in Hayward. The presentations educated participants on advanced healthcare directives and end-of-life issues related to hospice and palliative care. 80 people attended. On January 19th, 26th, February 2nd, and 9th, Dr. Victoria Leapart, gynecologist, presented Restoring Balance, a 4-week stress reduction program. 8 people attended. On January 23rd, Washington Hospital participated in the Health and Resource Fair hosted by Lincoln Elementary School in Newark. Washington Hospital staff provided health information to students, teachers, and parents. Over 300 people attended. On January 24th, Kimberly Alvari, registered dietitian, presented Healthy Meals and Food Safety to volunteers at Abode Sunrise Homeless Shelter in Fremont. The workshop provided helpful tips for those to prepare meals for the homeless. 60 people attended. On January 27th, Dr. Eldon B. Eichbaum, neurosurgeon, and Corey Langwell, physical therapist, presented Relief for Your Neck and Back Pain. 15 people attended. On February 3rd, as part of the Stroke Education Series, Dr. Ash Jane, cardiologist, Doug Van Houten, RN, and Luann Sadweste, RN, presented Living with Stroke, Future in Diagnosis and Management. 5 people attended. On Thursday, February 5th, as part of the Diabetes Matters series, Luann Sadweste, RN, presented Diabetes and Stroke, What is the Connection? 8 people attended. Upcoming health promotions and community outreach events. On Tuesday, February 17th, from 1 to 3 p.m., Dr. Stacy McDonald, obstetrician gynecologist, will be presenting Women's Health, Minimally Invasive Gynecologic Surgery. On Tuesday, March 3rd, from 6 to 8 p.m., as part of the Stroke Education Series, Dr. Ash Jane, cardiologist, Doug Van Houten, RN, and Luann Sadweste, RN, will be presenting Introduction Stroke, Risk Factors for Stroke. On Thursday, March 5th, from 7 to 8 p.m., as part of the Diabetes Matters series, Chung Mei Shi, RN, will be presenting Diabetes and Your Skin, How Uncontrolled Blood Sugar Affects Wound Healing. The Washington Hospital Healthcare Foundation Report. On January 26th, the Foundation held its annual meeting for trustees and members. At the meeting, trustees elected Peter Farber-Zakreni, Anu Natarajan, and Raj Salwan to join the Board of Trustees. Also elected as members of the Foundation were Nina Clymer, Patty Montahano, and Captain Jared Renetti. Rod Silvera was elected to a 2-year term as president of the Foundation. At the annual meeting, trustees approved the disbursement of over $168,000 to support a wide variety of clinical services at Washington Hospital, including cancer care, the community mammography program, diabetes education, childbirth and family services, and wound care. Washington Hospital Healthcare Foundation is proud to announce that it will host the 30th annual golf tournament at Castlewood Country Club on April 27, 2014. Held in memory of longtime Fremont businessman Jean Angelo Pisano, the tournament promises a day of great golf and fun surprises. Tournament chair Lamar Hinton promises another enjoyable tournament. He says, "We had a great round of golf at Castlewood last year, so gather up some friends and enter a foursome. It's a great day out and it's for a great cause." To reserve your foursome, please call Washington Hospital Healthcare Foundation at 510-791-3428. The Washington Township Healthcare District Board of Directors Report. Washington Township Healthcare District Board members attended the League of Volunteers Elegant Affair on February 6th. Washington Hospital Employee Association, WIA. In January, WIA held its annual wish list event in which various hospital departments submit non-budgeted requests for patient care items. WIA awarded $7,095 for items such as exercise equipment for cardiac rehab, single-use electrode kits for speech rehabilitation, crayons for pediatric patients, and special gas analyzers for the clinical lab. Washington on Wheels, WOW, Mobile Health Clinic. During the month of January, the Washington on Wheels Mobile Health Clinic, WOW, continued to serve community members at the Fremont Family Resource Center, the Fremont Senior Center, the Ruggieri Senior Center in Union City, as well as Briar Elementary School in Fremont. The total number of community members receiving health care at the Washington on Wheels Clinic during the month of January was 43. Internet marketing. Washington Hospital's website remains very active. The hospital's Physician Finder section was January's most viewed webpage with 16,949 views. InHealth Channel 78. During the month of January, Washington Hospital's cable channel 78 InHealth captured new programming, including a Diabetes Matters program, Diabetes and Your Eyes, a health and wellness program, back and neck pain, and the January Citizens Bond Oversight Committee meeting. In addition, InHealth aired a whooping cough public service announcement, Diabetes Matters insulin use, and the January Board of Directors meeting. Additional events. On February 2nd, the Washington Hospital Service League held their annual meeting. The installation of new Service League board members took place. In addition, the Service League donated $60,000 to Washington Hospital to purchase an Arctic Sun Temperature Management System, a non-invasive targeted temperature management system used to modulate a patient's temperature with precision by circulating chilled water in pads directly adhered to the patient's skin. Cooling a patient's temperature and slowly bringing the temperature back up can assist in recovery from cardiac and some neurological injuries. For more information on any of the programs mentioned, visit whhs.com or call 1-800-963-7070, and please follow us on Facebook and Twitter.
Okay, I'd like to introduce our February 2015 Employee of the Month. It's Donna Duran, RN. She's one of our EPIC principal trainers, and she's now working in our Information Services Department. Donna was born in Santa Maria, California, but she lived in Union City most of her life. She's a graduate of Logan High in Union City. She attended San Jose State University School of Nursing, and she graduated in 2000. Started working at Washington Hospital in August of that year as a new grad. Her career at Washington has gone through many changes. She started as a new grad, worked as a med-surg nurse on 6 West, a charge nurse, break relief, and then joined the EPIC team in June of 2011. She works closely with her IT and EPIC coworkers, physicians, nursing leadership, and nursing staff. She's part of the reason why we did so very well in our Go Live with EPIC. She's a chronic overachiever, and we know that anything asked of her will be done in a quality manner. She's the department's unofficial social director, making sure that everyone's birthday and special events are celebrated, and arranges outside events for team building. They go to the theater, dinners, bocce ball, showers, and so forth. She's also arranged the IT department Adopt-A-Family Christmas donations now for several years. She enjoys running and will be running her first half marathon this year, as well as her first Beta Breakers in May. I'll have to watch for her. She's also completed a half marathon, the Disneyland Tinkerbell Run, Neon Runs, and Turkey Trots, and numerous other fun runs. She's someone who everybody believes is quite deserving of this award. She's a team builder, a teacher, a mentor, and a great colleague. I'm very proud to have Donna as our Employee of the Month. Construction report.
Where's that?
We have Ed coming for our construction report.
Construction report, yes.
You can see there's dirt moving. It's exciting.
Thank you, Nancy. So, sort of our regular monthly update. We have a little bit of activity going on, particularly in the garage. So, since the last time, all the asphalt in the garage footprint has been removed. It's been recycled and to be used in a future date on the site. We also started underground utility work, mostly things like storm drains, things like that. And then there's also been a lot of work on what we call a fire line. So a line that basically surrounds the whole campus, what will be the new campus for fire hydrants, and then also that will feed sprinklers and things like that in the new buildings. And finally, we started what they call test boring, and test boring in the deepest parts of the garage structure. Make sure we don't have any problems with the water table or any other problems or obstructions. Now, this is the area, remember, we are not digging this out, we are just sinking piers to rest the garage on. And our time frame hasn't changed, that we're still looking at February. That's supposed to be 2016, my mistake for the completion. In the Hyman Pavilion, we're still in bidding. Any work you see out there is basically work for the fire line. We continue to get bids in. I guess the news since the last one is we had a significant overrun in our drywall bids. Came in almost 100% over what we had budgeted. So we have been working since these bids came in to find further reductions in construction with these subcontractors and other subcontractors, and we're making good headway. As you can see, we're over our budget from this group by about $8.8 million, and we're now we've identified about $5.5 million in reduction. So we're getting close to getting back to budget on the project. We are still moving forward with bidding and value engineering at the same time. We hope to have value engineering wrapped up this week, and then get our next set of bids in towards, well, it's next week as well. And we hope to then be awarding and moving forward with the first section, which is the building out, doing all the excavation work. So we expect to be starting that in March. The bids that we've got in for that work have all been acceptable, and they're all within our budget. It's the follow-on bids that we're working on. Okay? Any questions? Thank you.
Thank you.
Nancy, would you introduce?
We're going to have Mary Boron come and give our nurse-sensitive indicators report. But before she begins, I wanted to call the board's attention to this report. It is a validation of all the efforts that our nurses have made on behalf of our hospital and our patients to provide truly excellent care. This data will reflect that. I asked on fairly short notice that the nurses join us this evening. This is your night to shine. Everything you see should make you feel intensely proud of yourself as Washington nurses and as professionals that are exemplary for all of nursing. When I saw this today for the first time, it made my heart swell with pride. I was so proud to be the CEO of a hospital with nurses that can do these things. So I asked the board to sit back and enjoy. It's a moment of intense satisfaction that you're going to have. I'm so proud of them.
Thank you, Mrs. Barber. I agree. This is a really a time to celebrate. Looking at some of the data that we've collected, it goes over the last couple years, and it really shows and reflects the magnet level of nursing care that we have here today. This care is referred to as nurse-sensitive indicators. So before I get into the data, I want to spend a little bit of time talking about what that means. Nursing-sensitive indicators mean that they're really a quality measure that measures nursing care for you. So if you're looking at a way to meet the standard and look at how you can find out how your nurses are performing, it's done through looking at nursing sensitive indicators. They've been studied, they're reliably linked to quality care and patient outcomes. They reflect that you have structure and process in place. There are currently 15 nationalized recognized nursing sensitive indicators, which we will discuss later on. To get into it, we just to go back and think about why do we want to look at these nursing sensitive indicators. Again, because it's the national standard for measuring nursing care. It really helps engage nurses in the care that they're providing, and it gives them a way to measure what they do every day with their patients. And it keeps the patients informed about how clinically effective and efficient our nursing care is. A lot of this data is transparent now, so the clients coming into hospitals and stuff can really find numerous sources to dictate and indicate what our nursing care is like. It's a proven result to best patient outcomes. Our indicators directly link to improved nursing quality, and it really creates a culture of excellence for benchmarking against excellence, especially in a magnet facility. Some history on how we got here with nurse-sensitive indicators started back in 1994 when the American Nurses Association launched the Patient Safety and Quality of Care Initiative. They wanted to identify reliable and valid nursing-sensitive indicators, again, to keep consumers educated, policymakers, and to make sure that we're contributing to inpatient care well related to quality. In 1996, it moved further into California with the creation of California Nursing Outcomes Coalition, that's otherwise known as CalNOC. They've actually since expanded to other states. And then at the late 90s, we got the National Database for Nursing Quality Indicators, otherwise known as NDNQI. 2002, Joint Commission decided that this was also a great way to measure nursing care and bought into this process, and they incorporated nursing sensitive indicators into their standards for accreditation. So even Joint Commission is looking at this data closely. And in 2004, our National Quality Forum also looked at a measure set for nurse sensitive indicators. And recently, in 2007, the overall Agency for Healthcare Research and Quality, along with our Centers for Medicare and Medicaid, endorsed nurses sensitive indicators into our hospital value-based purchasing. As recently as 2008, the American Nurses Credentialing Center added nurse sensitive indicators as a requirement to achieve magnet status. You need to be looking at these indicators to get magnet status. Really is a way of demonstrating that you have excellent nursing. So as you can see, since 1994 right up to now, pretty much everybody has gotten on board with this. Everybody uses this as the standard to measure how well nurses perform. Getting back to CalNOC, in 2014, these efforts expanded beyond California. They went to Washington, Oregon, Arizona, Hawaii, and Northern California. Most of the hospitals that are participating are acute care facilities, 249 acute care facilities. Getting back to specifically what we do here at Washington Hospital, we take all of our nurse-sensitive indicators, we review them on a quarterly basis. When we review them, we look for trends. Are there events that keep on happening on certain units? Are there things that we notice have a spike, and immediately we want to take action and improve those outcomes? So that requires a lot of drill down. If there is an event like a central line associated bloodstream infection, that particular case is drilled down on with nursing leaders, members of quality, and infection prevention team. These are discussed at unit-based councils and committees, which means that they go all the way to the front line of staff. That's how we get them down. We use the shared governance model, and on the unit-based meetings, they discuss it. That way the front line, the people who are actually taking care of the patients, see this data, which is really important. And that helps us make our clinical decisions. For our magnet journey, we did start participating in CalNOC very early on. It was 2001. And then we also got on board with NDNQI early in 2008. So we've been participating in these databases for a significant period of time. And then in 2007, we received a grant from Gordon and Betty Moore Foundation that helped us perform a gap analysis on our progress towards magnets. So basically they said, this is where you are, this is where you need to go to get magnet status. So that was a big help in assessing the actions that we needed to take to become magnet. A second grant was also awarded in 2008 in support of our magnet journey to create awareness about the professional role of nursing and to help us establish looking at evidence-based practice related to nursing. We have been recognized for our efforts in Magnet. In 2010, we did receive our Magnet designation. This was a significant achievement for nursing. 4% of hospitals receive Magnet recognition. That tells you sort of how stringent the procedure and process is to obtain this. One of the instrumental members of our team in Washington Hospital in helping us get to this Magnet status was Martha Giggleman. During the time of applying for Magnet status, she was actually a student in a doctorate of nursing program. It was a fairly competitive program. She was there with about 12 other students. We had students everywhere from Stanford, Kaiser, UCSF, and the work that Martha did to achieve her doctorate that related to creating a Magnet collaborative where she brought together members in the hospitals in the Bay Area and sort of helped them facilitate achieving Magnet and facilitating communication among other hospitals. Her work in this was recognized in her graduation of December of 2012, and she actually received the Nurse Student of the Year for Doctorate of Nursing Practice. So that was a significant achievement for Washington Hospital. Currently, our update is that we're obviously continuing to focus on improving our nursing knowledge and make sure that all of our our outcomes for our patients are positive. We are in the current process of applying to be redesignated, and that application will be received in August of 2015. That's when we'll send that application in. So now to get in more closely to tell you what the nurses' sensitive indicator areas are, they're the structure of care, looking at how well are your nurses educated in your hospital, what's the number of hours they spend with patients per day they measure, how often do you assess patients for pain, and is that initiated within the first 24 hours of their stay. Patient-focused outcomes are centered around central line-associated bloodstream infections and looking at patients if they develop a urinary catheter infection while they're here. If they have any falls, do they get injured when they fall? Do they acquire a pressure ulcer while they're here staying? And we also look closely at how we physically restrain patients and what we do to prevent that from having to occur. Again, we look at this through 3 databases, the NDNQI, NHSN, which is the CDC government-based database that we report to for nurse-sensitive indicators also, and then CalNOC, as I've mentioned earlier. So getting into the indicators, this is where you can really start to see the success we've had when you look at this data. Starting off with the structure of how well our nurses are educated here. If you look on the first graph with the patients, with the nurses that work in critical care, we have exceeded the benchmark for what NDNQI expects us to have for nurses to have bachelors. 62% is what they expect. We've been over that. 68% of our nurses in critical care today have a bachelor's. Moving down into med-surg, this is a significant achievement in education for nurses. You'll see that the benchmark that they really expect in that group of nurses is roughly about 50%. Consistently, we've been over 70%. In the last quarter, 73% of our nurses in med-surg have bachelors. So how did we get there? We got there with a lot of buy-in and support from administration, from Mrs. Farber, from Stephanie Williams, making sure that we had a new grad program. This is a great way to get nurses introduced into nursing and provide them with the structure so that they can practice well. It's a very well-established program. We started in 2003. We've actually been able to hire 158 new grad registered nurses from 2008 to 2014, and 96% of those had a bachelor or higher degree. When the new grad programs are advertised, there's a significant volume of applicants that come through. The nursing education department takes every one of those applicants seriously. They go through, they spend lots of time looking at seeing that everybody has met the standard for education and look at their background, and they put in a lot of time and really come up with basically the cream of the crop of graduates and bring them through our new grad program. And it's been successful for us because 3 out of the 4 of our nurses have stayed after going through our new grad program. And looking at the hours that nurses spend with their patients, you think about how busy healthcare is right now for healthcare workers and how hard it is to really make sure that you get in there and you give those patients the face-to-face interaction that they need, and you sit in front of them and you listen to their needs and you work with them. This is a great indicator for looking at how well we're doing this in nursing. At Washington Hospital, on the med-surg unit, our registered nurses spend more time than average per day compared to the national hospitals. And it's not just a little bit more time. They spend significantly more time. You look at this graph, and the expectation from ND and QI is that, roughly 6 hours. Our nurses are spending close to 8.5, 8.4, and last quarter, last year at this time, 9.2 hours per patient in their day. That's a lot of good time to spend with your patients. Pain assessment. Anybody who has kids understands that when it comes to assessing pediatric populations early with pain and making sure they get the interventions, you understand how important that is, that thinking about children being in pain. And this is a real good assessment of, on our pediatric unit, over the past 5 quarters, we've performed more pain assessments on average compared to the national hospitals. Again, it's not just a benchmark that we barely made, we significantly made it over. 6.5 hours is initiated, is what they expect, and 8.1 is what we've reached. So I feel very reassured that our pediatric population is being assessed for pain well by nursing. Another one is patients who come into the hospital and are so sick that they're immobile and they can't move on their own, and it's really a reflection of nursing care how well their skin stays intact while they're here. These are patients who are really at the mercy of nursing staff to get in there and make sure that they're rotated and moved on their own. And as you can see from our pressure ulcers data, that we had no hospital-acquired pressure ulcers for the past 5 quarters. And we received a CalNARC award for this performance excellence in October of 2014. If you look at these graphs here, you can see that ND and QI is thinking maybe 4.3% of your population in a critical care setting may end up with a pressure ulcer. Recognizing that here at Washington, you have 0% for last quarters. Again, this is a reflection. Nurses are in the rooms, they're changing, they're moving the patients as they need to be, they're assessing their skin. We're working with FNS and assessing their nutrition, and these patients are not developing pressure ulcers here. And it's the same thing in the medical surgical side, same exact thing. Thinking roughly probably 1% of these patients would be developing a pressure ulcer. Here for us, it's been 0, not just for 1 quarter, for 5 quarters. So that's a really good sign that they're in the rooms and they're doing what they need to do for those patients. Restraining patients that were worried about being a harm to themselves, like pulling out lines, getting out of bed, all this. There's been a lot of movement in the last 10 to 20 years to make sure that we don't do that unless we absolutely have to. And we have a very low restraint prevalence rate, and you can see here that, again, if you're looking at the critical care rate of how often patients are physically restrained, very low, 5%. The standard that this database thinks is maybe 14.9%. We're significantly below that. Even better, looking at the patients in med-surg that have been restrained, there have been no physical restraints used in med-surg units over the past 5 quarters. That's significant. I remember when I was nursing in the 1998 and the late 90s, it was common. You just had patients in restraints, and we've really come a long way in nursing quality with this. When you look at, you see 5 quarters on med-surg without a single patient being restrained. They get in sitters. They try to help the family come in, support. They move them close to the nursing stations so they can have better visibility. CNAs round frequently to make sure that these patients are safe. We do anything rather than put these people in restraints, because you can imagine what that feels like for any patient. We really want to prevent it. Falls are another indicator that is reflective of nursing care. This one particular indicator is falls with moderate to severe injury. So not only in the case do these with the patient fall, they also become injured, and that's what we want to really look for closely. Did anybody fall? Did they sustain an injury as a result? Here we've had a decrease in falls with moderate to severe injury that was implemented over the past year. There's been a lot of initiatives to make sure that we don't have falls. The last quarter ending 9/14, you can see it was 0 again, above the below the CalNARC benchmark. Did not have any falls. The fall rate has really actually done very well for the last 3 quarters. Some ways that we accomplish that, we put low boy beds, which are beds that are very low to the ground. So if you assess a patient and nursing says that this patient is high risk for falls, first thing they do is get a low boy bed in place. So a bed that is low to the ground, so that if unfortunately the patient does rule out, the fall is non-existent. Again, nursing assistants rounding to make sure that these patients are in bed, that they're safe, that their needs are met, that they've been helped to get up to go to the bathroom, because that's one of the incidences that happens that leads to falls. And we have a lot of staff education about how to assess patients to see if they're at high fall risk. That assessment happens very quickly upon admission with the patient. And if a patient does end up on a high-risk medication like an anticoagulant medication, which would mean that they would bleed more significantly if they fell, they're even considered at higher risk. So we watch this population very closely, and the result is that we're having a lot less falls. Another one is when patients have a urinary catheter in place, anytime you put a medical device in a patient, you run the risk of infection developing. And we've had less of those infections than what the National Healthcare Safety Network expects. Again, that's the CDC database. So what they are looking at is to say that the yellow line up at the top is telling you that you probably would be likely to have 1 infection over the quarter, at least, of patients on a med-surg unit who had a catheter. For the last 5 quarters, you can see we have been able to stay under that 1.0 benchmark. Same thing with critical care. Critical care, that's a much bigger challenge. Those patients tend to be sicker. They tend to have catheters for longer. Same thing. We've been performed better than expected for majority, 80% of the past 4 quarters. This is a real significant achievement. The other one is central line associated bloodstream infections. Again, patients who have a medical device placed in them to get their IV antibiotics, their fluids, can't get it in a smaller vein, so we place it. It's much more of an invasive line that provides the patients with their IV medications and everything that they need. Unfortunately, again, if you have a central line in place, you're at risk for developing an infection that can get in your blood. So if you look at the data on quarter ending 9/14, in med-surg is slightly above the benchmark, but the other ones before way below it. Critical care is a higher risk environment for developing central line bloodstream infections. There's been a lot of interventions made by the critical care nursing team to make sure that the patients don't develop central line infections. They've significantly reduced that over the past 5 quarters. As you know, we have a huge focus on hand hygiene right now. I think that's helped a lot. We implement devices that we put on the IV lines. Our device is called Kuros. It's on all lines. It's a little green cap that covers and protects the IV line. Nurses put that in place. They also round with and discuss with the medical staff daily that if the patient doesn't need this central line, it needs to come out. Because if the central line comes out, the risk stops. You don't have to worry, obviously, about them developing an infection. It was just last week I received a call from our infection preventionist about a patient in ICU. This patient was fairly sick. She was improving. They were trying to get her transported to the med-surg floor, and it was really good to hear that the PIC nurse, the infection preventionist, the bedside nurse all advocated to say, look, let's get the central line out. We don't need it anymore, and work together with the physician, and they got it out. That's an example of how we prevent CLABSI here. The future direction of where we're going with looking at nurse-sensitive indicators is we're going to continue to participate and submit our indicators to track performance. We'll always evaluate improvement opportunities. We can always do that every time any of these events happen. There's a lot of effort through shared governance and task forces to prevent further events from happening. Again, we're working towards that redesignation in 2015. And one of the added benefits to providing this kind of quality care in nursing is you do receive CMS incentives for it. This care is being looked at. You can really get some good incentive payments on it, and if the care is not done well, it's the reverse. The payments go away. So it's important from that aspect also. As I mentioned before, I think that our CNO, Stephanie, has had a huge impact in leading these improvements. and helping the frontline staff in doing that and giving them the opportunities and the tools that they needed. I would like to invite her up here to speak to the great nursing staff that we have that's arrived tonight to support us with this celebration.
Thank you, Mary. These results didn't just happen. They happened because of consistent, evidence-based practices by our nurses on a daily basis. I want to thank the nurses for their dedication, their commitment to providing safe, high-quality, reliable care to our patients. I thank each and every one of you. I am so proud of everyone. Thank you all. Together we make a great team. Thank you.
I would like to personally thank each and every one of you. When you say the word patience, it's kind of general. There's no personalness to it. But recently I've had a number of people in my life who've been admitted to this hospital. And the care that has been given is very, very good and very thoughtful and very kind. And I'm very appreciative of it because I can put a name and a face to those patients. And without the care that you've done, without the efforts that you have given, these are numbers, but I see the patient. And I have to say from the deepest part of my heart, thank you. It's very, very important that we remember each one of those patients is known by somebody in this community, and they have a face. Thank you. Would some of the other board members like to comment?
I'd like to just thank the nurses for coming tonight. It's an extra effort to be here tonight. I know you work long hours, and it's hard to just show up for a meeting like this, but I'm glad you're here, that we can thank you. I was particularly impressed with some of those bar graphs. I had to look for our results. They were all zero. It was really exciting when Mary put a couple of those up on the screen. I thought, well, where are our results? Our results were there. They were zero. It was wonderful to see that. Thank you very much. I really appreciate each one of you being here tonight and able to say thank you to you personally. Thank you very much.
Madam President, I think you got it right when you said those are statistics, but where the real heart of the matter is in the care that's delivered at the bedside. And, I think I'm the luckiest board member here because I'm one of the ones who gets to see all of the hard work that you do day in and day out. As Stephanie said, it's persistent, hard work, delivering that evidence-based care, which results in the improvement and dramatic results. I mean, when you take a look at the skin integrity numbers, that is remarkable to be able to deliver a year without a pressure-related ulcer. That is just fabulous. And that just doesn't happen without every nurse paying careful attention to each patient at risk every day that they're in the hospital. And so it's pretty, no, it's really impressive what you guys have done. And I thank you for that. And I know there are a lot of patients and families of patients who thank you for all the hard work that you do.
Thank you again.
I just want to add that many times when we look at the numbers and the results, it's all about how you pull the rabbit out of the hat. But it's really not about pulling the rabbit out of the hat. It's how you put the rabbit into the hat in the first place. And I think a lot of that has to do with the education that our nursing staff has achieved in their lifetimes, and then also not only in the institutions of higher learning, but on the job and working with each other and growing from working with each other, I think is one of the reasons why we got the rabbit into the hat and why we're benefiting by all the great results that you produce all the time. So thank you very much.
Thanks, Mike. That was nice.
Very proud moment.
That was very nice.
I was thrilled when I saw that. I think they've worked very hard and it shows.
It does show, and I just know that they're going to get Magnum again. It's there. It's in the stars. Now, just prove us right and go do it. So we can brag about you some more. Thank you. Thank you for coming. Okay, next on our agenda is the finance reports by Chris.
Okay, tonight I'm pleased to present the operating activity and resulting financial performance for Washington Hospital for the month of December 2014. We'll move right into our operating indicators. Average daily census for December came at 148.6. We'd expected 165.1. We had 976 admissions, about 94 less than what we expected. Our patient days came in at 4,606. We'd expected 5,119. Outpatient observation equivalent days came in above budget at 273, and our average length of stay was 0.39 below budget at 4.39 days. Moving into utilization, case mix index for the month was pretty close to budget at 1.497. We had 159 deliveries in December, 21 above what we had expected in the budget. Surgical cases came in 4 above budget at 341. That includes our joint replacement cases that were 4 below budget at 108. Our neurosurgical cases for the month were 3 above budget at 21. And we had 10 cardiac surgical cases against a budget of 11, so pretty close there. Cath lab procedures were 145 above the budget at 691, so the cath lab was very busy in December. Outpatient visits were 63 below budget at 6,998. Our emergency room was busy in December and continued busy in January. December saw 165 more visits than we expected in the budget at 4,469. Quick look at our cath lab distribution. Again, peripheral vascular, not a lot of change here from the prior month. Peripheral vascular, the largest slice of the pie at 30%, followed by cardiac, non-vascular and other was the largest slice of the pie at 42%, followed by peripheral vascular and cardiac. Looking at our FTEs, our productivity. Productive FTEs for the month were 54.1, below budget at 1,100, almost 1,102. We had 209 non-productive FTEs in December, giving us total FTEs that were 46 below the budget and 1,310.9. Our FTEs per adjusted occupied bed, which is our productivity measure, came in pretty close to budget at 6.42. So we had some lower activity and management did a pretty good job of flexing the staff down during the month. Moving into financials, as always, we'll look at our Governmental Accounting Standards Board presentation first. This is the presentation that we use for our audited financials. Net total patient revenue for the month came in about 2% below budget at $165,493,000. Our contractual write-offs for the month came in at 77.17%, a little bit higher than budget, and again, we're seeing that additional government payers in the mix coming from the Medi-Cal expansion. So we ended up the month with net operating revenue almost $1.4 million below budget at $37,936,000. Operating expenses for the month came in 11.3% below budget. Biggest driver there was a reduction in our reserves for bad debt and charity of a little over $3 million. And again, that's reflective of that shift out of the private pay bucket up into the Medi-Cal bucket And just to give you some context, generally, we've seen our private pay as in the mix of revenue at 3 to 4%. In December, it was 1%. So we really are seeing the shift there. Also contributing to that positive variance was, of course, salaries and wages with our lower FTEs. We were a little bit over budget in our purchase services, and that was driven partly by a special assessment we received from CHA to fund the labor management commission that came out of the last negotiation. Also, we had a little bit higher than expected hospitalist fees during the month with some of the activity. So overall, ended up with a very good month in December with an operating bottom line of $2.361 million, a little over $3.1 million above the budget. Non-operating income for the month came in at $549,000 below the budget at $543,000. We did have about a $500,000 unrealized loss on our investments during the month as the markets continue to bounce around. So we ended December with a total bottom line of a little over $2.9 million against a budget of $294,000 from a GASB perspective. Take a quick look at our Financial Accounting Standards Board format. And again, to remind folks, this is the way the financial markets would tend to look at us. Operating bottom line stays the same at $2.361 million. We remove our revenue for the debt service on our general obligation bonds and that unrealized loss on investments to come up with non-operating income from a FASB perspective of $268,000 and a total bottom line of a little bit over $2.6 million from a FASB perspective. So are there any questions on December? Okay.
Are you ready for the statistics report? The preliminary results for January. This month saw 1,178 patient admissions. Our average daily census was 184, 5 lower than the budget, and 0.9% above the budgeted average daily census. January last year was 178, somewhat higher than last year, and our high and low census ranged from 214 down to 128. Our outpatient observation equivalent days of 263 were higher than the budget of 226. Based on discharges, the average length of stay for adults and children in January was lower than budgeted at 4.72, higher than December's average length of stay. The birthing center saw 147 deliveries in January, compared to the budget of 142. We had 321 baby days of care, and our newborns totaled 151. By comparison, a year ago in January, we had 140 deliveries. In surgery, we saw 356 surgical cases, one case above the budget. It's pretty sharp budgeting. This included cardiac surgical cases that were 1 above budget, neurosurgical cases that were 5 below budget, and joint replacement cases that were 3 below budget. General surgery cases were above budget by 8. Inpatient surgical activity was on budget at 288, and outpatient surgeries were above budget. A year ago, the number of surgeries we had were 366. The outpatient surgery center continues to have higher than expected volumes. They had 590 cases, and they had budgeted for 570. For the month of January, total procedures in the cath lab were 622. We had budgeted 606. A year ago, the overall cath lab volume was 584. As you can see, this is a product line that is beginning to grow and develop. We were 39 more procedures than anticipated. 23 were outpatient procedures. And they came in, I'm sorry, I got that garbled, I'm sorry. We had 39 more than anticipated in the cath lab. The outpatient procedures were 7.6% less than expected, or 23 cases under the budget. Cardiac procedures were 3 above budget. Peripheral vascular procedures were 4 above budget. Neurointervention procedures were 10 below budget. Non-vascular interventional radiology procedures were 14 cases higher than the budget, and the ancillary procedures were 5 above budget. Non-vascular interventional radiology procedures include gastro, urinary, and musculoskeletal procedures. Ancillary procedures include blood draws, moderate sedation, thrombectomies, transfusions, and other supporting procedures necessary in providing comprehensive care in the cath lab. In terms of our non-emergency outpatient visits, they came in 6.6% lower than the budget. We had a total of 7,687. The emergency room recorded a total of 5,164 patients, a daily average of 167. This was 422 above the budget and 455 above January a year ago. This was the highest recorded monthly emergency room volume on record. We have census data 2 days apart, 1 week apart, where we hit 202 patients in the emergency room in a 24-hour period of time, and then less than a week later, 204. Emergency room staff are very deserving of praise for all of their hard work. I know the rest of the house has been working hard too, but the emergency room has been particularly hard hit by this surge of patients, and they have managed very well. In Washington, Warm Springs, Newark, Nakamura, and Ohlone clinics saw approximately 4,178 patients during January, 54 more than had been budgeted. So our total system emergency room and clinic visits for January came in at 9,342. We had budgeted 8,866. For personnel, our full-time equivalents for the month of January totaled 1,333.5. That included 12.6 agency personnel. This was 82.1 lower than the budget. Productive FTEs were below budget by 130.8 for the month. Non-productive came in at 48.7 FTEs above budget. I'd like to point out about the personnel numbers that our staff is not immune to the flu. And just like the general population has succumbed to the flu, so do our employees. And with the flu shot not being a good match for the influenza strain that is circulating, we've seen a lot of that. At the same time that's going on, it was going on at every other hospital, and getting registry was next to an impossibility. Our staff have really had to work hard to get through this month. Our productive FTEs per adjusted occupied bed came in at 4.54. Our budget had been for 5.2. In terms of our patient mix, our preliminary information indicates that inpatient revenue for the month of January amounted to approximately $137.8 million, compared to a budget estimate of $141.1 million. Of this amount, 61% was Medicare, including Medicare HMO, and 14.7% was Medi-Cal, including Medi-Cal HMO. Let's see. I think that's enough on that. Revenue for the month was under budget by $3.3 million, or 2.4%. Outpatient revenue, that was the inpatient revenue. Outpatient revenue for January, by comparison, was above budget by $1.6 million, or 3.6% positive variance. The inpatient revenue variance is due to lower acuity surgeries done in the OR. The outpatient revenue was higher than budget primarily due to the increased outpatient activity in the OR, cath lab, and emergency room, as I mentioned before. So in summary, we had 5 fewer admissions and 52 more inpatient days than we had anticipated in the budget. Our surgical cases are above budget. The cath lab procedures are above budget. Outpatient visits for January came in 6.6% below budget, and ER visits were 8.9% higher than anticipated. Clinic visits for the month were above budget by 1.3%. Our total paid FTEs were below budget by 82.1, or a 5.8% variance. Inpatient charges for the month were below budget by $3.3 million, as I mentioned before. That's a negative 2.4% variance. Our outpatient charges were higher than budget by approximately $1.6 million, a 3.6% positive variance. So our total hospital charges, our healthcare system charges for January, were below the budget by 1%. We're almost there. On January 31st, there were 173 days cash on hand. The total days revenue and accounts receivable at January 31st was 67.4. If we exclude Medi-Cal, it was 65.2. Excluding the Alameda Alliance, it was 66.1. The Alameda Alliance remains a very significant challenge, and not just to us, to the physicians in the community as well. During the month of January, $478,775 of charges were approved or are pending for charity assistance.
Thank you, Nancy. Next item on the agenda are action items for consideration. First item.
Madam President, in accordance with district law, policies, and procedures, I move that Chief Executive Officer be authorized to enter into the necessary contracts and proceed with the purchase of the hardware, software, and implementation services for the Citrix NetScalers for an amount not to exceed $77,782.40. This is an approved project in the 2015 capital project budget.
Do we have a second?
Second.
Discussion?
Yes, I want to point out that this is a system that will give us the ability to lock down external access to our applications. It's a big security advantage. Will also provide the ability to require those users to have an approved antivirus application to access our environment. So it's very protective. It adds front-end optimization to ensure performance, scalability, security, and resiliency for remote users. It helps protect web applications against attacks from web-based internet virus or hacking. And there are other additional benefits that go along with performance, load balancing, and content switching, and all those other things. But for me, the single most important feature is the security that it gives us. So I request the board to adopt this motion. I think it's very important.
At this time, I would like to ask if there's anyone in the audience that would like to make comment on this particular item before we proceed. Seeing none, would you take a roll call for the vote, please?
Director Danielson?
Aye.
Director Wallace?
Aye.
Director Stewart? Director Nicholson?
Aye.
Dr. Eapen is away.
Motion passes. Thank you very much. Next item for consideration.
Madam President, I move for the adoption of resolution number 1152, which is the resolution of the Board of Directors of Washington Township Healthcare District for a tobacco and smoke-free campus.
Do we have a second?
Second.
Lots of seconds on this one.
Everybody wants to second this.
I like this one. Nancy, could you please explain to us
Yeah,
and to our public?
we adopted some rules years ago around cigarette smoking in the hospital and banned it. We still provided a smoking shack in the backyard for employees who felt they needed to smoke. And from time to time, physicians would write orders that gave permission to patients to go outside and smoke. And as the years have gone by, it has come to my attention that we are not consistent with industry standards, and that the vast majority of hospitals across the country have already adopted policies such as this. And I think that we're more than prepared to go forward with this. It's, I think, an absolute requirement of a healthcare institution to take a stand on this and say no more. It provides for no smoking of marijuana or tobacco, no chewing, no e-cigarettes, no tobacco products whatsoever. And I think that it's an important statement for the district to make. I personally am tired of walking up the front walkway and stepping through all of the cigarette butts that are left at the front door. It is a dirty habit. People put their cigarettes out in the planters. They're all over the garden. They're everywhere. And I think it's time to do what so many other hospitals have done. It's not a healthy habit.
And I would like to clarify that this is not just within the hospital proper. It's throughout the entire campus,
Yes.
including the clinics everywhere.
Yeah.
So.
It does not include the shopping center,
Correct.
but everything else that's healthcare related.
Thank you.
I feel particularly good about it because the Surgeon General of the United States in the early 70s was from my hometown in Aliquippa, Pennsylvania. His name was Jesse Seinfeld. And he was warning the country about the dangers of secondhand smoke, and as well as smoking. And because of the pressure from the tobacco companies, Richard Nixon fired him. And he went on to have a career mostly testifying against the tobacco companies during the 80s. But he was a hero in my small hometown of 15,000 people.
Okay, in the name of Aliquippa, here we come.
Here we go. Yeah.
Good for him.
Yeah.
Good
And that's
for
a
him.
really interesting story. I had no idea.
Yeah.
Okay, and again, at this time, if there is anyone in the audience that would like to make comment on this particular motion, seeing none, thank you. Colleen, would you take roll?
Director Danielson,
A very, very strong and happy aye.
Director Wallace,
Aye.
Director Stewart,
Aye.
Director Nicholson,
Aye.
Dr. Ethan is okay.
This motion passes. Thank you. Next item.
Madam President, in accordance with the district law, policies, and procedures, I move the Chief Executive Officer be authorized to enter into the necessary discussions and agreements in order to reestablish Washington Hospital Healthcare System's new graduate program for nursing and specialty care training programs for a total amount not to exceed $1,517,780.
May I have a second, please?
Second.
We have a motion and a second. Nancy, would you explain and go further what this new grad program is all about?
There's a piece of information that's worth commenting on before we get into the nuts and bolts of Washington Hospital. Kaiser Healthcare System has announced the hiring of 400 new registered nurses in the San Francisco Bay Area. I don't think there are going to be very many nurses left on the market, and nursing availability will become a serious problem. But quite apart from that, I am recommending the reinstitution of the new graduate program for nursing at our hospital. A number of our long-term nursing staff and some of our specialty care areas like the operating room, the cath lab, and maternal and child health are going to be retiring in the near term. We're also recommending that we reinstitute internal training programs for existing employees in these 3 specialty areas. Since 2003, we've hired 271 registered nurses through our new graduate program. Over 96% of our new graduate program nurses have a bachelor's degree, and 3 out of every 4 of the new graduate nurses have chosen to stay on at Washington Hospital for 7 years or longer. So the retention is excellent. Specialty training for operating room nurses, for labor and delivery nurses, has been eliminated from most nurse training programs, and that's resulted in a shortage of nurses going into these specialty fields. So if you want them, you're going to have to grow your own. Nurses who've gone through our internal training programs in the operating room, maternal and child health, and cath lab have proven to be some of our strongest clinicians. And we have very high retention rates, similar to that experienced by the new grad program. So we think it's time to reintroduce the new graduate program for nursing, and we'd like to get 11 new RN graduates. We would like to train 4 of the existing med-surg nursing staff in labor and delivery, nurses that are interested in taking that course. 4 of our existing med-surg nursing staff to be trained in operating room nursing, and 1 of our existing CCU nurses to receive training in the cath lab. The breakdown of the cost has been given. It's overall a $1.5 million prospect. The annual savings goes something like this. It'll take just a little bit over 2 years for it to pay for itself. Wages for registry nurses, assuming they're available, are higher, and I think that this is a very cost-effective way of assuring the institution that it has a sufficient supply of new grads. And I would ask that the Board of Directors pass this request and give me authorization to spend this money. I think that we're going to see a nurse shortage, especially with what Kaiser's planning to do.
It's a good plan. Again, if there's anyone in the audience that would like to make comment on this item.
Madam President, I'd like to make a comment.
Certainly.
I can't see that we could spend this money in a better way. I mean, I think this is an extraordinarily effective program. It's been in existence for a long time, and I've had the pleasure of seeing many nurses who've come in as a new grad go through the training and really become professionally mature and then go on to become leaders in our nursing staff. So this is a huge investment in the future of the nursing staff of the hospital. I'm sure Dr. Lunny has comments. I mean, he's seen a lot of these nurses come through as well.
Definitely agree. Some of our strongest nurses are ones that have been homegrown, essentially.
It enables us to hear reports like we did tonight. Yeah, that's a good thing. Is there anyone in the audience? Seeing none, would you please take a roll call, Chloe?
Director Danielson?
Aye.
Director Wallace?
Aye.
Director Stewart?
Aye.
Director Nicholson?
Aye.
Director Ethan is away.
Thank you. Motion passes. Next item, please.
Madam President, in accordance with district law, policies, and procedures, I move for the approval of the Medical Executive Committee proposed revisions to the medical staff rules and regulations, Article 2, Section 10, infection control policies, requiring all medical and allied health staff to comply with the current hospital policy regarding tuberculosis screening for healthcare workers.
Thank you. Do we have a second?
Second.
Nancy, would you like to comment on this as well?
No, I think our chief of
Well,
staff is
I
sitting
was
right
giving you
here.
first choice, and then it was going for Dr. Lenny.
Basically, TB screening is sort of critical because TB is a bacteria that can cause a lot of devastation, particularly in the lungs, but in other body organs as well. And there are currently policies at the hospital for all employees, staff, and volunteers to have annual TB testing to detect whether an individual may have been exposed to TB and carry latent TB, which is treatable. And it was uncovered during the last Joint Commission survey that the medical staff didn't have a similar policy. So this is to correct that deficiency and now adopt the same policy for medical staff as other hospital employees and volunteers to be
Very
tested
good.
annually. And hopefully, if any individuals in the medical staff are discovered to have latent TB, they can be treated and put in a position where they won't be getting infected themselves or infecting any of our patients.
Would any of the other board members care to comment?
Nope.
Okay. Any comments from the public? Seeing none, Colleen, would you please take the roll call?
Director Danielson?
Aye.
Director Wallace?
Aye.
Director Stewart?
Aye.
Director Nicholson?
Aye.
Dr. Ibanez away.
And that motion passes as well. We're done with the action items, and we will now adjourn to a closed session. Thank you. We are reconvening to open session and reporting that there was no reportable action taken during the closed session. And with that, this meeting is adjourned.